expecting you. What? Don't tell me you don't recognize me. Oh, still don't know who I am. Let me try and help you with that. I'm the ill ease that you feel when you walk into a crowded room. You know, the hot and cold flushes that confuse you when you're already confused enough. I am the one that raises the whip to your already racing heart. I am the tightening of your chest, the snowballing worries that feel like they might become an avalanche and can just bury you in an instant. My friend, I am the obsessive and I'm the compulsive. I'm the voice, you know the one. It's always questioning everything you do, everything you think. And I am every single staring eye that watches you. And every one of those places that you try so desperately to avoid. So, now that we have become acquainted, what are you going to do about it?
Anxiety, my old friend and myself. But anxiety is a state of apprehension, tension, and uneasiness in response to a perceived threat or stress. It is considered normal and adaptive when it is temporary or temporally restrained during a stressful or uncertain situation. However, prolonged, intense, or inappropriate periods of anxiety may indicate an anxiety disorder. Stress activates the hypothalamic pituitary adrenal axis, or HPA axis, which, in concert with other physiological responses, coordinates our normal behavioral responses to our environment, or the fight or flight response. Recall that the HPA axis, very much associated with the hypothalamus and pituitary, is tightly associated with the sympathetic nervous system. Phobic disorders are intense, irrational fears centered on an object, activity, or situation that a person avoids. Anxiety disorders, like a panic disorder, are recurrent attacks of intense fearfulness, and generalized anxiety disorder is persistent excessive anxiety and worry. In abnormal psychology, you probably learned a lot about anxiety disorders, and really that's their territory. I'm just going to briefly go over these, but memorizing these and the DSM criteria and all this, that's for abnormal. Here, I'm mainly going to test you on, the treatment and the neurobiological basis of the treatment. But the primary anxiety disorders are generalized anxiety disorder, panic disorder with and without agoraphobia, specific phobias, social phobias, obsessive compulsive disorder, and post-traumatic stress disorder. So again, I want to reiterate that there are appropriate response, or anxiety is an appropriate response under stressful circumstances. However, there are a variety of biological, pharmacological, and environmental factors that can cause anxiety. I mean, obviously, repeat exposure to stressful events, Like warfare, for example, is one. Being in an abusive relationship, domestic abuse, childhood abuse. These are typical environmental variables. There are drugs that affect the central nervous system that can cause anxiety, like caffeine, alcohol, cocaine, antidepressants, nicotine, and amphetamines. Alcohol is a good example. It's thought and argued by some, like George Koob, the current head of the National Institute on Alcoholism and Abuse, that the rewarding effects of alcohol have very little to do with long-term alcohol dependence and abuse. Rather, it is the negative effects that accompany what happens when you stop drinking, namely anxiety. When you are coming down off of alcohol, or the next day when you wake up, the anxiety is known to get worse over time. So, like when you first start drinking alcohol, experimenting it, like with a college student might, you might experience more of the pleasurable effects. But over time, those are diminished, and instead what you're left with is, basically a constant state of apprehension and anxiety when you are not drinking alcohol that really drive continued alcohol use. There are also biological factors, including brain chemical imbalances, personality traits, faulty perceptions, irrational beliefs, and unresolved emotional conflict. And all of those, I might add, have a biological correlate. Benzodiazepines are currently one of the most common ways of treating anxiety, although technically SSRIs are really the first thing a physician might consider, in part because benzodiazepines have abuse liability. And, like alcohol, which also acts on GABAergic systems, it's believed, comes with severe or withdrawal that can actually increase anxiety over time. But it is very true that acutely benzodiazepines are quite effective at treating anxiety. Benzodiazepines are anxiolytic, meaning anxiety-reducing drugs used to treat anxiety. Very common examples are Valium, generic name diazepam, and Xanax, generic name alprazolam. They bind to GABA A receptors and enhance GABA A's inhibitory actions by increasing the flow of chloride ions into the cell. They do this by functioning as an allosteric modulator at the GABA A ion channel, something that I'm going to detail, further here in the next few slides. But I also want to point out that serotonin, drugs and SSRIs are also used to treat anxiety. What we know is that if you increase serotonin levels, you actually induce anxiety. So the idea here is that with an SSRI or a serotonergic agonist, you actually are going to blunt or retard the postsynaptic reaction to the heightened serotonin that might be evoked during a stressful event. And through this mechanism, it is thought that you would sort of deaden or soften the effect postsynaptically of the heightened serotonin release. So we've already talked a little about D2 autoreceptors versus heteroreceptors. Again, recall like haloperidol, a D2 antagonist, would actually antagonize the autoreceptor on the presynaptic terminal, which would result in an increase in dopamine, but that dopamine isn't going to do much because it's going to be blocking the postsynaptic response. Well, 5-HT1A receptors also are the autoreceptor for the serotonin system. 5-HT1A receptors act as the presynaptic autoreceptor on the serotonergic projection neurons from the RAF-A and as postsynaptic heteroreceptors in most regions that receive serotonergic input. The anxiolytic effects of 5-HT1A receptor agonists may involve both the autoreceptor and the heteroreceptor. You might get instant relief by binding to that autoreceptor, but if you overactivate the postsynaptic receptor, maybe you will actually deaden its response over time. It could work either way. One interesting observation is that recent evidence indicates that cannabidiol is a 5-HT1A receptor agonist. Therefore, the anxiolytic effects of cannabinoids could be due in part to the action of cannabidiol at the 5-HT1A receptor. It might, if when acting at the autoreceptor, reduce serotonin release. And if the increase in serotonin is producing an anxiogenic effect, it would counter that. Now, just a little bit on the animal literature that indicates this. There's been really a wide array of studies taking, optogenetic manipulations, pharmacological manipulations, and lesion studies, basically all across the board, showing that, if you increase serotonin levels, you make the animal more anxiogenic. For example, if you place a rat in an open field and, increase their serotonin levels, stimulate the dorsal raphe with channel rhodopsin and blue light, they're going to hug the walls because they produce more anxiogenic effects. If you then suppress serotonin release using halorhodopsin, the prediction would be that they would spend more time in the middle of the open field, which would be very risky for a rodent that has a strong prey drive. So how do those benzodiazepines work? Well, they bind to something called allosteric sites on the GABA A receptor complex. So again, the GABA A receptor complex is a pentameric structure that basically forms a pore or a tunnel through the plasma membrane, allowing chloride ions to flow into the cell to hyperpolarize it. Really, there should be 5 units in this picture. There are 4, but whatever. And you can see that there are 2 sort of lock and key sites there, one for GABA itself and the other for benzodiazepines. It is not yet known if there's an endogenous ligand that binds to the benzodiazepine site, but you would think that there would be. Logic would suggest that. Now, what in the absence of a natural ligand, GABA, the chloride channel is closed. And, if the benzodiazepine site binds in the absence of GABA, nothing happens. That is what an allosteric site means. But it would potentiate the effects of GABA when bound, which I will show you in the next slide. So what really happens when GABA binds to the GABA A receptor is it produces a conformational shift, resulting in the tunnel emerging for chloride ions to flow through. Now, it is perfectly efficient on its own, but what you'll see in the next slide is that benzodiazepines, when bound to that allosteric site, make it even more effective. So when benzodiazepines bind to the distinct benzodiazepine binding site on the GABA A receptor complex, it increases the apparent efficacy of GABA, meaning that the channel is open more frequently. Benzodiazepines would have no effect in the absence of GABA, which differentiates them from barbiturates. Barbiturates are more dangerous and are more likely to kill you. It's what is thought that Marilyn Monroe overdosed on, for example, because they are GABA mimetic. Meaning they can produce a GABA effect or a GABA-like effect, even without GABA on board.
In synapses where GABA acts as the neurotransmitter, an action potential releases GABA, which then opens a GABA receptor, allowing chloride ions into the postsynaptic cell. GABA is inactivated by being taken back into the axon terminal through the process of reuptake. GABA agonists such as barbiturates and benzodiazepines also bind to the GABA receptor, which may also lead to an influx of chloride ions. When both GABA and a GABA agonist are bound to the receptor, more chloride ions enter the postsynaptic cell, increasing GABA's normal effect.
So I did want to touch on one particular, what's technically classified as an anxiety disorder, Tourette's. Tourette's patients may have heightened sensitivity to tactile, auditory, and visual stimuli. It is diagnosed early, typically at the age of 6 or 7, and children may exhibit attention deficit hyperactivity disorder and obsessive compulsive disorder. Here's a chart or graph just showing some of the motor tics, vocal tics, and compulsive actions often observed in patients with Tourette syndrome and their median age of onset. One interesting observation is that dopamine D2 receptors are denser in the caudate nucleus of a patient with Tourette syndrome. This is even seen in twin studies. These differences in the dopaminergic system could be important, and interestingly, dopamine D2 antagonists are effective treatments or offer effective pharmacotherapy for patients with Tourette's syndrome. You see similar effects following long-term haloperidol treatment, actually, in the case of, which would result in sort of a supersensitive postsynaptic D2 dopamine response. And, you see that after long-term typical antipsychotic treatment. This is simply a image from your book demonstrating the increased binding to the dopamine D2 receptor. I forget what drug they used here. My guess is going to be raclopride. Raclopride, in a PET study, what you do is you add some radioactive ligand to a known pharmacological compound that would bind to a particular receptor. In the case of raclopride, D2. And you can measure the amount of displacement. If there is a lot of displacement, that would suggest that there is more dopamine D2 receptor, which is exactly what you're looking at, and that is how that would be inferred and is the basis of PET imaging. PET imaging is particularly effective for looking at, receptor number, specific receptor binding sites, where receptors are localized, these sorts of things. Whereas fMRI, on the other hand, would be better for looking at changes in blood flow or metabolic activity, which is possibly associated with changes in neural activity.